Hello and welcome to EHJ Today. My name is Stefano Taddei and I am International Associate Editor at the European Art Journal. We are speaking from Barcelona. We are here for the annual meeting of the European Society of Cardiology. And it's my privilege to introduce you Professor Stefan Janssens from Belgium and Professor Michael Marber from King's College in London. And we will discuss with these distinguished colleagues about the possibility to use nitric oxide in acute coronary syndrome, and the specific study is the NOMI study. So Stefan, please, can you introduce us the study, the rationale, why did you decide to perform such kind of clinical trial?
Well, thank you. NOMI was really a challenge for us as we wanted to explore whether something that we had discovered and worked on for a long time in preclinical models would translate into a benefit for patients. It's quite unusual in cardiology that a drug, when given through the airways, would affect the function or the structure in the heart under certain disease conditions like myocardial infarction. And that is exactly what we had discovered in animal models with several other investigators on both sides of the Atlantic. We therefore wanted to know whether if you give nitric oxide via inhalation, we would be able, in a rigorously designed trial, to confer protection to patients with myocardial infarction. And the specific question we ask is, can this therapy via the airways reduce infarct size?
Okay, so how did you plan the study, the experiment, the number of patients, the experimental design, single center, multi-centers?
Right, so we looked at infarct size in contemporary studies with myocardial infarction. And one of the most rigorous ways to quantify infarct size is magnetic resonance imaging. So we looked back at studies, not only in our center, but in many centers that had carefully measured infarct size in patients that you and I would see every day in the cardiac catheterization lab with STEMI. We then figured that if the trial would be able to show a difference of a reduction in infarct size by about 25%, it would be worthwhile and translate into a clinical benefit based on the assumption that infarct size translates into outcome in these patients. And we powered NOMI to detect a difference in infarct size and not to detect differences in clinical outcome as a first exploratory phase 2 trial. We felt that it was important to do it multicentric because of centers that were had very large experience with inhaled nitric oxide in preclinical models might be more prone to test the hypothesis that this trial or this therapy would translate in benefit. We wanted it to be translatable to other centers that had no prior exposure to inhaled nitric oxide strategies. So that was one of the reasons we decided to do a multicentric trial, and we insisted on a rigorous blinding procedure so that no patient nor any of the investigators would know whether patients were receiving active gas or control.
Okay, and how many patients did you enroll?
Based on the power calculations, we enrolled 230 patients. That was the minimum. We enrolled 248 patients to account for some missing data and dropouts in terms of intolerance for magnetic resonance, and we achieved to randomize these patients.
So, and now the results.
Well, the results are quite intriguing. We had pre-specified that we would look at infarct size as a percentage of the mass of the left ventricle, and in the overall population of patients we did not see a significant reduction in infarct size as a percent of the LV mass. However, what we did not know, and what our preclinical work was never able to investigate, is whether or not the treatment with inhaled nitric oxide would interfere with contemporary treatment strategies that are used in certain sites, such as the use of intracoronary or intraarterial nitroglycerin, another nitric oxide donor, or 2B3A antagonists, which are often used in the cath lab in the setting of acute myocardial infarction. And we were very surprised that in a pre-specified subgroup of patients, those that received no additional nitroglycerin infusion, the benefit was significant, or the reduction in infarct size, I should say, was significantly smaller with the inhalation of NO. And that is something that I think is the most intriguing finding of this study.
Okay, and Mark, your comment about that?
So I mean, it's great to see an academically led trial in this very difficult setting. I mean, there are a number of interesting aspects to it. So I think the principal endpoint is negative, but as an academic trial, it had lots of other exploratory endpoints which throw up questions. And Stefan, I think what you're hypothesizing is that basically you can have too much of a good thing. So you think that inhaled NO on top of an intra-arterial organic nitrate may potentially cause harm. Is that the hypothesis? And in the absence of an organic nitrate, you see the benefit of inhaled NO?
Right, and there is some additional data that would speak to that. There are trials that have looked at prolonged administration of organic nitrates, which need to be bioconverted in order to release nitric oxide. And that bioconversion is something that's driven by different enzymes, which in the setting of acute myocardial infarction may not function well, and hence not liberate nitric oxide, but cause oxidant-free damage. And we would hypothesize, of course we need to show it, and we have all the bio samples to investigate this, that in the absence or in the presence of organic NO donors, you cause increased harm by excessive radical formation. And that's one of the hypotheses we have.
So if there is a sort of a dose-response relationship to the benefit and a sweet spot, a therapeutic window where NO is capable of reducing infarct size, when you give a drug by inhalation, which is unusual in cardiology, you've got changes in tidal volume, minute volume, transfer function in the lungs. There are all sorts of things as cardiologists we don't normally think about. Do you think they become important factors?
Well, it's a very good point. So we have lots of patients that we have worked with inhaled NO over the years for different sorts of applications. The most predominant effect you see with inhalation of nitric oxide is twofold. One is it vasodilates lung vessels, resistance vessels in the lung. And so in patients with pulmonary hypertension, you would see a beneficial reduction in the pressure in the lungs. In our patients with normal baseline pressures, and we excluded in the trial patients with congestive heart failure, there you don't see an impact on pulmonary pressures. That's been investigated very thoroughly. Second interesting point is that with inhaled nitric oxide, you target circulating cells in the lungs. And you target monocytes, white cells, platelets when they circulate. And in the case of STEMI, they are quite activated and quite angry and aggressive. And you can deactivate these cells, and that's been shown in many animal studies as well. Then we think it could contribute to some of the benefit. So the pulmonary function tests that would be affected by inhaling nitric oxide, as we did here, have not been shown to be significant in terms of vasomotor responses in airways. You could envision that in asthmatics you can influence tidal volume or resistance to airflow, but in normal patients, as we excluded patients with COPD and desaturated baseline oxygen levels, we didn't see any effect on the airways.
So now, just to conclude as a final statement, how do you intend to go further in this area? Which are the steps in this area of research?
Well, as Michael alluded to, this is an academic trial, and so it was really set up to try to answer different mechanistic questions as well. And so what we would love to do is try to really focus on that sweet spot that we may have identified and try to see whether in a larger prospective trial where we would rigorously control and stratify for the use of intracoronary or intraarterial NO donors, we would still be able to confirm the trends that are in this exploratory trial. And if that were the case, then of course we think we would create added value for patients with STEMI.
Okay. Stefan, Michael, it was great to have you here, and thank you very much.
Thank you.